So for patients who have an IDH mutation up until August 6th, this is really how we've been thinking about these tumors. So you had a tumor, you took it out, you determined whether or not it had the IDH mutation. If it had the IDH mutation and it was a 1p19q co-deleted tumor, then you knew that it was an oligodendroglioma, and then you would rely on your pathologist to sort of see, does it look like it's growing slowly? Does it look like it's growing mediumly? And that would help us kind of grade these tumors on a score of either 2 or 3. Now, if you had this IDH mutation and you did not have this 1p19q co-deletion, which means that it's intact or normal, then that was an astrocytoma, and you would either be able to grade it, again, slow growing, or if it seemed like it was moderately dividing or dividing more quickly, then you would grade it on a score of 3 or 4. And so depending on what this tumor was and how much the surgeons were able to take out and how the patient was doing after surgery, there's all of these different options. And really, most of our clinical trial data is looking at radiation and chemotherapy. This has been the gold standard. We know radiation is helpful. We know adding chemotherapy to radiation is helpful, pretty much regardless of which one of these tumor types that you have. Sometimes people who have all of their tumor removed, those tumors might just be monitored closely. And again, many of you have probably been on this trajectory. There may be some small examples where we would think about a chemotherapy alone for a certain subset of tumors, but there's really a lot of choices, and it can be very difficult to make these decisions as the clinician and, of course, with you as the patient. I think people who have these IDH mutated tumors really are running a marathon. They may live decades with their tumor, and we know that decades of living with something after radiation, for some people, not all people, but can have slow impact on their cognition, ability to work, help take care of their families, live the high thrive, with the quality of life that they wish to have. And so trying to avoid or trying to time radiation correctly has always been something that neuro-oncologists have been interested in doing. However, that is really where most of our data is. And so those sort of living in those two different worlds has been a very difficult place for me and all the patients that I've cared for over the last 10 years.